Yes.
Okay. Our guest is here. She is the Principal Secretary in the State Department for Public Health and Professional Standards in the Ministry of Health. Then it has two state departments. Mary Muthoni is the PS. Good morning.
Good morning.
Welcome to Fixing the Nation.
Thank you.
I'm
here.
Hapa, finally you're here.
The last time we met,
Yes.
or we had an interview like this, I was talking about one prisoner, one bed, one mattress.
Yes. You
One bed, one mattress.
Yeah, you started that push
Correctional services.
at the correctional services. And here you are now.
Now I'm here.
You have settled in that ministry very well. So you will answer all our questions from top to bottom. I have some shout outs for you
Yes.
from fans. Jane Joki, unamjua? She says she's from your hood. She says, good morning, fixers. Good to see you. I can't wait to watch the girl from my hood at 7 a.m.
Niko na mafans.
Fans.
So, mafans lazima nimemsalimia.
Yeah.
Yes.
Karibu sana.
We
And
come
then
from the great county of Kirinyaga.
Kirinyaga County.
Yes.
Okay. Janet will give you the day's quote.
Yes, today's quote is from Zora Neale Hurston. She was an African-American author from many, many decades ago. She wrote a book called Their Eyes Are Watching God. That was in 1937. Sometimes I say those dates and I'm like, 1937 just sounds like hundreds of years ago. And in there she said, there are years that ask questions and years that answer. Where do you think we are? Are we in the year that asks questions or the year that has answers?
We have to be answering.
Okay.
What has been asked in the past. You know, even when you look at the evolution of man, when you look at the acceptability of women in society, we have many things to actually thank God for and also to implement. When you talk about policies, we are here to implement that which was written by somebody who probably is no longer there. You know, people who thought about the health of this country, they envisioned how it should be. When the Constitution of Kenya, somebody wrote and said that everybody has a right for an available, acceptable, accessible, and affordable quality health care. We must answer that question. And not yesterday, now.
So we're in the year of answers.
We're in the year of answers. Okay, let's try and get some answers around public health right now.
Yeah. So we know the Ministry of Health, and then we also know that there are two PSs and two state departments.
Yes.
Medical Services, and then Public Health and Professional Standards. Dr. Umo Luga is in the other one. And now you've been in this one for Public Health. What do you do? What's your job? And how different is it from Dr. Umo Luga?
Executive order created the two state departments, Medical Services and Public Health and Professional Standards. And basically, it's talking about preventive and curative arm. So I will particularly dwell on what I do. And our work is very simple. One, to create policy development, policies in regards to related to public health, related to sanitation, related to infrastructure. That is why we have KMPDC that goes around inspecting the facilities that are out there to see whether they are worth. And equally, preventive and promotive health services. We are also very keen about that. So we oversee the provision of preventive and promotive health services. And that includes immunization programs, where health education, health promotion activities. You have realized that my department talks about healthcare workforce. And when we talk about healthcare workforce, it's development and end-to-end, you know. We talk about production. We have our premier institution, that is our Kenya Medical Training College. And from there, like now we are graduating more than 24,000 graduates every other year. That's what we are churning out. So policies around that, around human resource, health education management. You have seen we have rolled out people like the community health promoters in the who are moving from door to door, and that is one of their mandate, to have health education, food safety and nutrition. Whereas health is a devolved function, the development and of policies that are related to food quality and infectious diseases is in our mandate. We also have health research, because when we talk about numbers, it is important to make decisions based on numbers. And planning, when we go to budgetary processes, then we use numbers. Therefore, it is in our mandate to make sure that we are doing research and providing the important information in the health space. Equally, the regulation of quality assurance in our facilities. Right now, we are in the process of developing the quality of care and patient safety bill. And this is going to protect the patient. Many a times is when we have been interested in the how beautiful our infrastructure is, but we haven't really been keen as a country on how is the patient. Is she or he happy? By the time you walk out of that facility, did you see the practitioner who you were supposed to see, or somebody was at home giving instructions through the phone? So again, issues to do quality assurance, regulations, and generally monitoring of our health sector issues, which is very, very critical. And some of the activities that we are handling now is the rolling out of universal health coverage. So comes with that. Of course, observing sustainable development goals. That's why you've seen a lot of PPPs, partnerships, and especially probably equipping our facilities where the government may not have the money per se to take very pricey equipments to facilities. And I mean, we are with the Kenya Kwanza government, so ensuring the Kenya Kwanza manifesto is followed. We have 4 agenda in the Kenya Kwanza, and health is one of them, alongside agriculture, housing, 5 actually, not 4, alongside agriculture, housing, MSME, digital economy, and agriculture. Therefore, we are in that space.
It's a big one.
Yeah,
and the issue of prevention, promotion is in our hands. Just to make sure that if there is something that smells that like COVID, we are ready. And we are ready to protect the nation and its citizens. Now, before you ask me any question, I want to take you a little broader, because once the ministry was set with the 2 state departments, a house without a base or without a structure is as well as a shell. And the first thing that we did was to come up with acts, the laws that will govern and the laws that will help us to cascade down and help us to reach the people. And one of the laws that we came up with is called the Primary Health Act of 2023. The Primary Health Act is the one that has recognized the community health promoter. Initially, even my own sister used to be a community health worker. Then it used to be called workers or volunteers, but they never used to be paid. They were simply giving service to the communities. But now with this government, we came up with a structure to recognize them in the law, that we know there's a person called the community health promoter. And these are their roles. This is what they have to do with the people, and we give them a stipend. We don't pay them. We give them a stipend, something to say thank you for the work that you have done for the community. Again, we have also seen the establishment of primary health care networks, in which a primary care network, popularly known as a PCN, is the mapping out of facilities, geographical mapping out of facilities. When you register to SHA, it gives you the facilities that are near you. They are within a primary care network. So that is also entrenched in the law. We were supposed to have 315 PCNs across the country. I know we are gearing towards that. We are way around 230. And within no time, we will be able to accomplish that. Then the second act is the Facility Improvement Financing Act of 2023. And this act, basically what it means is ring-fencing the money that is meant for health to remain in health. Many a times is when even with the allocation of the counties and you know when budgets go to the assembly, the parliament, sometimes you'll see later on they are reallocated to different functions. So you'll find the more critical areas in health, they are left unattended. But now with the Facility Improvement Financing Act, we are able to ring fence any money, whether it is through the normal budgetary allocation or through donation. Nobody should reallocate that money for something else.
Okay.
It should remain for health, to ensure that it deals with issues, infrastructure, issues to do with the employment of human resource, equipment, and commodities.
Like medicine and all. So we talked about the four
I want
laws.
to finish the four laws.
The four laws that you came up with.
Yes,
So
which I need to finish
one,
because
the infrastructure, the
Facility
Facility
Improvement Act. Then we have the Digital Health Act of 2023 that really helps with the interrelatability of data. When you move from one facility to the other, then you don't carry the quota exercise books that we used to carry when we were young children. So everything is integrated in one system. And equally, we also have digital superhighway, where we know human resources for health, how many are in the country, we are able to tell. Then, and the final one is the social health. The Social Health Insurance Financing Act of 2023 that now came up with SHA.
Okay.
With the Social Health Authority.
All right.
And you know, under SHA, we have three funds.
Okay.
We have the Primary Healthcare Fund, we have the Social Health Insurance Fund, and we have the Emergency, Chronic, and Critical Illness Fund.
Okay. Let's pause there so that we can begin to engage. I mean, you've painted a very elaborate picture of the scope. But I know right now, top of mind, there's a couple of priority issues in the country. There's NCDs, infectious diseases, there's UHC matters, there's SHIF and SHA. You know, some of what is, you know, we've collected what, is it 67B of 157B? Are those the latest numbers? So I just want to start with your entry right now. You've spoken very broadly. What are you putting in place? We've had several conversations here about things like cholera. What was the other one that we learned about yesterday?
Chikungunya.
Chikungunya. Tell us about how these are being tackled, because these are now sort of like urgent emerging issues, and just how, whether the public health sector is going to manage with regards to policy rollout and just trying to address these matters.
I think COVID taught us a lot. And we built in a lot of structures during COVID time. We have not demolished those structures. We are riding on them. Whether it is in terms of surveillance, whether it is in terms of inspection, in terms of human resource, we continually train the human resource at the county level. And that is the capacity that we build, whether with this chikungunya, this cholera, and we've had many emerging and re-emerging issues without going to specifics. Some of them being a comeback, some of them being new. You know, we've had Mpox the other day when we had to be very vigilant at the border with surveillance, ensuring that anybody who is coming through the border is inspected, training of the multiple groups that are at the border point. So really, we already have policies, and that is why when you asked me, are we in the past or in the future, are we answering questions? We are continually answering these questions because the policies are there. And the one thing that we can do is basically to implement them. Our role is to keep cascading this information even to the county level. Remember, health is devolved. So implementation is squarely at the county level, and we cannot work in disintegration. We work very coherently. We are able to communicate to the Council of Governors. They are able to release their officers if there's any training, if there's any structural thing that needs to be done, then we do together. So the country needs to become, we are in control of any diseases, and I have seen people talk about flu. Really, we are going to July, and this is expected.
July
has come very early.
You know, and we also need to know, unlike before, we have many other causes. We have climate change issues that have hit the global arena with a bang, you know. And climate change is extreme weather conditions. And whether it is too hot or rainy, it affects you in one way or another. So all these challenges are there, but we are on course, and we are able to tie in some of these things using the healthcare workforce and professionals who are there. One Health, if it is in the Ministry of Agriculture that has to combine forces with the Ministry of Health, then we are able to do that.
You're able to.
Yeah.
You know what, the one thing that I always think about is we have very good structures. Even if you look at our structure for UHC and the planning for it, even just starting from that, what you're saying, primary care network. If I am here, I'm mapped to the facilities around me, whether public or private. Level 1, which is a community health promoter, to level 2, 3, like that. All good. Vitu ground. PS. We see, yes, there's a number of community health promoters that have been employed, and we are paying them a stipend.
Yes.
Are they well facilitated to offer me the service? And by facilitation, I mean, do they have the requisite equipment that they need? Do they have the information? And is there a direct source of information on this is what you need to go and communicate to the community right now? Ni season ya homa, watoto wavae mboshori, and so on and so forth. Are they well equipped? The community health promoters, and then I'll come from there and go into the other cadres of health workers.
Very good question. Let me first paint a picture of what the community health promoters have been able to do since we launched them. Up to this morning, they have been able to screen for diabetes, a whopping 29 million people. That's across the country. Remember, one community health promoter serves 100 households. And out of those 100 households, in a month, you might be able to even visit each of the households. So out of these 29 million people, 340 people have been referred to a health facility for further testing and assessment. Hypertension, 19 million people have been able to be screened. And this is across the country. I've not gone into county per county. And out of these, 672,000 people have been referred to a health facility because the community health promoter will not treat you. They will only assess. They'll only screen. And out of that, 672 have been told, Wewe, hii blood pressure yako iko juu. Go and get checked. You don't know what is happening.
Yeah.
Pregnant women, remember we have Linda Mama, and there are women out there, the ones who say mimba sio ugonjwa, so they stay until delivery time. It is upon the community health promoter to identify these mothers within their 100 units and tell them, please go for antenatal. And as of today morning, 344,000 have been identified. Just to say there's a pregnant woman in this home. 134,000 have been told you have not gone for your prenatal. Please visit. The community health promoter equally, they are able to assess common childhood ailments. They are able to tell whether a child has malnutrition, or you need to take this child to be checked in a facility because they have been trained. To answer your question, we have a curricula for the community health promoter on all the roles that they are supposed to do, and they have already been trained. But training is continuous. Even today, there is a county being trained on a different issue. Maybe it could be on tobacco use. Maybe it could be on cancer. It could be on something else.
Malaria prevention.
Malaria prevention. So training continues every other day.
Who supervises the CHP?
We and the county government. The oversight is conjoined.
Okay.
There are people called community health assistants. And each community health assistant is in charge of 10 community health promoters. So you are supposed to know what they are doing on the ground, whether they have gone to the household or they have not. However, we have come up with a community health registry, a digital community health registry. And what we are going to do is to also geomap. We will be knowing whether a community health promoter has gone to a certain household, because they will be reporting in their gadgets. Remember, they have
when
kits.
When will this happen?
This kit, it's happening right now. I have a dashboard every morning that I check that community health promoters, how many have gone to the field today, and they have reported. They report on their phone. Where we are going right now is to key in how, if you have given commodities, maybe dawa za minyo, have you been able to dispense? We had not gotten to that point, but that is where we are going right now. But have we been able to be in the field? Yes, we can tell that these are community health promoters. They have a phone. Jane has gone to this household. They have been able to see that household has this number of people. They have advised them that the number of people, you need another latrine or thereabout, because they are able to also talk about sanitation. Remember, Kenya still has 15 counties that practice open defecation.
Right.
So we are also very keen.
I think it's 47.
And we'll come back and answer that. We're going into a break, but that's fair.
Everywhere in every county.
Right.
There are
there's matters open. That's fair. So we'll come back and answer.
But at least that's the ones that have already been passed.
Okay, we're going into a break. Yes, we're going into a break.
Okay.
We need to. It's 7:30. Stan Kimaru says UHC without medicine and workforce is zero. That's some of the comments that are coming in, but it's 7:30. Fixing the Nation on NTV and Nation FM. Send your questions, your queries, your concerns. We are in studio with the PS, Mary Muthoni, so she's going to be able to speak to some of those, including what Mariam has just said. We'll be right back after this break.
Zero. So let's get back into that. So you've talked about the CHPs and whether they are facilitated. You're also in charge of training of healthcare workers from KMTC to our universities and making sure that they go in there and then they're absorbed. Senior. And licensing them. And then facilitating them. Now, we have been seeing people who go to university for 6 years and then they zoom for at home because they've not been posted to internship. This is just breaking down the training cycle. And then they're not licensed as doctors, so they can't practice. What's been the challenge with that?
Thank you for that question. And I know it has been a dicey space before. You've seen people striking because of the same. and really this is one of the things that we must fix for this nation, because indeed UHC without workforce is dead. We can have all the infrastructure, we can have all the equipment that we need, they're very sophisticated. We can have the commodities, but if we do not have someone to dispense the duty, then it is it's dead. There are many things that go through that. One, health being a devolved function. Like the national government, we don't usually employ per se, because unless the ones that go to facilities like Kenyatta, MTRH, everybody else is county government employee. But other than that, this is an area we have been conversing with the county governments to have a middle ground, like the issue of the universal health coverage staff who are employed or were given a contract back in 2020. And 5 years down the line, they have not been able to be settled anywhere. So some of these are intergovernmental issues, and we are in conversation to ensure that budgetary allocation is given to some of these issues. Because of this fiscal space that we have been in, it's been really difficult to serve the welling space. Initially, you'd find, like the University of Nairobi, they have a cutoff of the number of doctors they need to train. But over time, they have doubled, tripled, and even made it 10 times the number of doctors that have been are able to be trained. And so is many other cadres. And the mushrooming training institutions that are coming up every other day. And remember, even those who train outside the country, they come back home and say, we want to go for internship. I mean, the country may not be in that space to afford every now and then. So we are coming up with the policy, internship policy, and healthcare workforce policy to ensure that we streamline this space, because really we don't want to keep going round in circles and telling people we cannot post you because we don't have enough money, or we have to reduce your money so that we fit in. But we also need to regulate the number of trained care staff that are out there. Our universities, remember, we don't regulate the universities. They are regulated under the Ministry of Education through Q, the CUE. Therefore, we are doing interministerial conversation to see that we are connecting and we have cohesion in this space. So I may not want to preempt what is already on the table.
Okay, but this one you can preempt. we have UHC workers who have been out on the streets for weeks now, and they've just been saying, we have been working on this contract, it needs to move from contract to another. Your ministry and the Council of Governors are in a tiff here. First of all, you've been paying ghost workers. Even your cabinet secretary has admitted this. How did you end up with ghost workers, PS? Secondly, how do we address their concern that they want to be paid just like their fellow health workers? Start with the ghost workers.
You know, everything in...
How do you end up with ghosts?
No, everything in government has a process of ascertaining something, and we have audit to be done, and that is what we are saying, that indeed, if they are ghost workers, then let us do a head count. Let us know who exactly do we have. Are there people who have already left this program out of attrition, or they have already been absorbed by the county, they have left the country for other interests? So we want to ascertain that number so that even when we are defending the budget, we know exactly what we want, not holistically saying the UHC staff, they were 8,500, you know? They could have gone down as low as 7,000. And that's what my CS is really talking about. And we are in agreement. We are not in conflict with the county government, by the way. We are not in conflict. It is simply conversation that is continuous. It is only that sometimes that conversation leaks into the public, which is meant to have been finished in the boardroom. So allow us to finish what is in the boardroom so that we can come to the public. And things are not bad, really. I have seen progress in that front.
Right. Oh, There's so many public health matters that we'd love to touch on, and I want to get some responses. Vaccines do fall under public health, right? No. That's interesting.
Well, it's a public health issue.
Immunization.
It's a public health issue, but we, as you very well know, we have division in terms of
between the two
state departments.
State departments. All right, so you can speak to the shortfall of critical vaccines, right? Okay. The matter then of not vaccines, but what was it that I want to talk about? Vaccines was one, UHC workers was the other. There's another matter, but I'm still really wondering about the issue of vaccinations. But it's okay. Let's go into now safety, sanitation, and a lot of the diseases that come as a result of changes like we've talked about in weather, in climate change as a whole, flash floods here, there. Yeah. What are we doing more preventative? Because I think that's where we usually fall off the track. We tend to be reactive as opposed to, preventative.
First and foremost, the State Department has come up with a program called Epuka Uchafu Afya Nyumbani. And this basically is divided in 3 areas. We have personal hygiene. We have seen school-going children going to school and sneezing on each other. And probably they have not even been taught the manners or even given as simple a thing as a handkerchief. So personal hygiene ranges from, have you cleaned your hands today? Can you first tell me? Have you cleaned your hands today?
Yes.
Yes. So make sure today you keep asking everybody whether they have cleaned their hands. All right? And then we move to environmental hygiene. Environmental hygiene ranging from how do you treat your home? Do you clean your compound? Have you cut the grass in your compound? You know, environmental hygiene also talks about issues to do with climate change, the extreme weather condition. When there are flash floods, what do we do? Members of the public should not build where there are hills or something like that. Then we have sanitation, water and sanitation. Remember, most of these preventable diseases, they come from dirt, water, food, and they can be prevented. It is something you and me can do easily.
Right.
Like ensuring if you cook food that is just enough for that night, and if there is a leftover, then make sure it is boiled. Don't eat when it is just heated lukewarm, ensuring that issues to do with sanitation. In this country, we still have 15 counties that practice open defecation. And remember, having a toilet and a latrine should be equivalent to the number of people that are in that household.
It's a right.
It is actually a right.
What do you mean by equivalent? One toilet per person?
I can give you the data much later.
Oh, okay.
But you cannot have 100 people sharing one toilet in one home or one latrine. So it is upon us to ensure that we educate the members of public on how this should be. And that is why we have the community health promoter. Community health promoter is our level 1. The one thing that we are very keen about in this country right now is screening. Even if you look at how SHA is working, much of it is preventive health. That even issues to do with mental health have been factored in the primary health care, in the secondary, and also in the tertiary. We have issues to do with the screening of cancer, and other ailments. Therefore, screening is one of the things that we are emphasizing very much to the members of the public. Do not wait until you're told your blood pressure has hit the roof. Go to a facility, tell them check. Or if the community health promoter has advised you or has referred you to a health facility, please adhere to that. So those 3 things are very critical: personal hygiene, environmental hygiene, water and sanitation. As a state department, our work is to partner with the county governments so that we are able to implement the policies that are already in place. Because we don't need to keep writing more policies. We quite have substantial number of policies that can be implemented on the ground and be able to guide people. We have laws that are already guiding us now on the masses on what they are supposed to do. And should you get unwell, then make sure you register to the Social Health Authority so that you can use your ID to go to a facility. As at this morning, we have more than 23 million people who have already registered. In a day, 40 to 50,000 people are registering to the Social Health Authority because they have seen how it can assist. Probably there could be some issues that need to be adjusted, and that is why the Cabinet Secretary, who is my boss, launched the tariffs committee to ensure they listen to the people, and they also look at using numbers. Decision making is better done using numbers, and see what are the tariffs that we can adjust to help the common mwananchi. We've already done for cancer. It used to be 300,000. It's been improved to 550,000. We've already done for the admission, which used to be at 3,000. 4,000, depending on the level of facility, up to 28,000. So this is the kind of improvement, you know, Kaizen, continuous improvement that we are talking about.
We are very short on time. A few questions coming in. Jose, talking of sanitation, most urban centers don't have sewer systems. Subsequent governments have failed to resolve the issue. He also, so there's comments and questions. Why has it been so difficult to establish a health worker service commission to deal with the HR component of healthcare from a national perspective? Grace Kiru, what plans does MOH have to ensure continuity of HIV care services? I actually hope we can speak to the plans for funding, given that there's a lot of funding that has been pulled back on critical areas around HIV and AIDS. And maybe we can start there, if you can give a brief update of what happens now, because now there's a massive gap.
On issues of healthcare workforce and healthcare commission, remember this was not entrenched in put in the constitution when the constitution was coming to play. However, we came up with the Kenya Human Resources for Health Commission, KHRAC, we call it Advisory Council. And this is work ongoing, because if we have the council, then we can improve to whatever else that we look. But can we first allow them to at least do something for now before we think of forming another institution? I think what is bedeviling us sometimes is having so many institutions that are duplicating roles, and at the end of the day, we end up not achieving that which we have envisaged. So we have KHRAC for now.
So how long has it been in operation?
It's been in operation for 2 years.
Okay.
So we still have a lot to do, and I have already told you that we are in the process of having the human resources for health policy that is going to be in place, and that is going to touch on internship, labor migration. It's going to touch on professionalism of the healthcare workforce. So we are not sitting pretty, looking at how the situation has been. And I totally agree. Yes, indeed, we need to do something on the healthcare workforce in this country.
Funding. The gap in the funding.
Yes, the gap in the funding. We have gone back into local resource mobilization. It's the high time we worked on our programs to ensure that we are able to align to the country's need. Many a times is when we have very haphazard way of operation. We have so many small programs out there doing the same thing. So we are aligning to that to ensure that the programs are aligned to what the government is looking up to, and the local resource mobilization that I'm talking about. Ensuring that government is also injecting funds to health. And because we have the laws right now, we are not guessing what we need to do. We already know that we are rolling out universal health coverage. So much of the funds that come to the Ministry of Health should go to the program that we are rolling out. So there are many other ways, and also looking for PPPs, public-private partnership. I have already told you the issue of equipment, where the government does not have to really have the money, but we have people who have the equipment and they can install them in our facilities on lease or fee for service. When you get the service, that is when it is paid. So there are many ways that we are dealing with this space, and we really can only say we are looking forward to the very best.
Right. Before we close, there's a few things that I may not necessarily fall again under your State Department, but they are issues of public health. And one that keeps coming up on the comments is the issue of vaccines, the shortages again. And another one that also keeps coming up is fake drugs. There's been a few recalls over the last year of some drugs in the market. There's also proliferation of counterfeits, and seems to be it's a public health issue.
And misuse.
And misuse as well, yes. For things other than they were registered for. Please speak to those.
On the issue of vaccination and the drugs that we could be having a shortfall, it would be important that we have a conversation, because it's quite broad, really, and there could be aspects that have been there that you may not know. So if you invite me on Monday, I'll come and we can speak about drugs extensively. But just to mention, some of the drugs that have been recalled from the market, we have become very vigilant on the use and misuse of drugs through our Pharmacy and Poisons Board. And that is why you have seen that activity happening. We have been able to caution the members of public on the misuse of drugs again because of antimicrobial resistance. We have many people out there who just walk into the chemist and they buy antibiotics. Then the day they get unwell, the drugs don't work on them. So we've been very vigilant to also speak to it to ensure that people do not misuse drugs and over-the-counter medication. You are not a professional, so I don't know why you would go to the chemist and ask for a specific drug. In our digital system that we are coming up with, we have the track and trace system that is going to track the drugs away from the manufacturer, the country of origin, and where it is headed to, the consumer. These are some of the things that we are dealing with to ensure that we curb that. And probably you haven't asked me about tobacco use.
That was the next question.
Oh, it was.
You banned the importation of tobacco, and there's some tobacco products that the government is really, really unhappy with. Talk about that briefly.
Is it the government unhappy with, or including you are unhappy with some products? And I want to make it clear, we banned the clearance of tobacco products. The people who we had allowed to bring in the products in the country or manufacture, we want to clean up that space. We want everybody to come and tell us, this is where we work, this is our store, this is the product, this is what it contains, this is the tax I'm supposed to pay or I have already paid, because we collect 2% Solatium fund money that forms our Solatium fund. The market had become so infiltrated until we did not know what we were dealing with. So it is important to ensure that we streamline that space so that we are able to safeguard the people of this country. If you see the people, the number of children between 10 and 17 years who are already taking vaping, more than 100,000 already. And that probably, it's 165 according to
we're just vaping.
10 to 17 years. I'm talking about children. Forget about yourselves now. I'm talking about children. The rise of smoking among the women is actually higher than the men right now. Because of the appealing products that are coming into the market. They are appealing to the children, they are appealing to the women, because we love nice things, packaging. According to Tobacco Control Act of 2007, there are guidelines of how to package, and you're supposed to tell the people that this may kill you. So that has not been happening with some of the manufacturers and merchants. Again, we have already released 17 graphic health warnings that must be put in all those products.
Including the vapes?
Including the vapes, including the pouches, including the cigarettes. So all nicotine products must adhere to the Tobacco Control Act. And basically, that's what we are doing to enforce. For the public good and for the sake of public health. And indeed, it would be important for children maybe to make their decision when they are 18 years, whether they want to vape.
We're closing in a minute. I'm very sorry to interrupt you.
I have so many stories, Janet.
Yeah, but we need to be keeping it concise. There was a story about Ozempic use. We have a minute to time.
About?
Fake Ozempic, fake Ozempic drugs being used.
What you're talking about, the abuse of licensed drugs, licensed for this and being misused for the other, and you've seen...
in just under a minute, if you're able to, because of time.
Yeah. Our pharmacy and poisons board are already in the act on that, and I'm sure we have a good report around it on the action that are being taken, so that we can be there for the public good. Therefore, it would be important to know that we are actually on the move in regards to drugs as use, drugs abuse. If there is any use, let it be prescribed by a professional, and ensure that you don't walk into a supermarket or into a pharmacy and buy yourself drugs.
P.S. Thank you for joining us. Yes, come again soon.
Yes.
So we can talk about, especially on the issue of drugs and substance abuse and the health effect of that. Mary Muthoni is a Principal Secretary for Public Health and Professional Standards. She's been our guest, telling us about what we are doing to fix our ailing health sector. Keep it here. The next hour, we give somebody, one of our fixers, the mic, and they're saying June 25th should be a national holiday. Keep it here for that.